Sure.
Hey, hopefully this sounds good to everyone. Uh, Good afternoon and welcome to the Lynn Cancer Institute. This presentation by Dr. Richter will be a part of our survivorship lecture series. And today's topic will be conversations in radiation, facts, myths, and your questions. As I said, we'll be learning from our very own physician, Dr. Sam Richter, a radiation oncologist at the Lynn Cancer Institute. We are very fortunate to have physicians who treat our cancer patients on a daily basis. Professionals who are so deeply committed to improving the lives of the patients in our community that they, like Dr. Richter today, will go the extra mile to answer questions that our patients might have and at the same time educate the rest of us. At the Lynn Cancer Institute, we believe that education and awareness, prevention, screening and early detection, a variety of treatment options, our latest technology, the expertise of our staff, the benefit of our multimodality method of treatment, all combined, will truly help to save lives. In the interest of time, Dr. Richter's bio was sent to you by email. And during his presentation, we invite you to please take notes. And when you have questions, all along you can put them into the chat box or the Q&A box. And as he just said, he'll have time at the end of this presentation to answer any of your questions. So thank you all for joining us today. We have a great audience, Dr. Richter. And I'd like to introduce now Dr. Sam Richter.
Thank you, Jan. Sam Richter, radiation oncologist in the Department of Radiation Oncology at the Lynn Cancer Institute. I work in our Boca office, Delray Beach office, and our Boynton Beach office. Can you guys hear me? Yeah. Good. I appreciate the introduction. And today, talking about radiation oncology, I've always wanted to create a talk or have an open sort of digital forum with prospective patients, current patients, and members of the staff to talk about radiation therapy, just commonly asked questions that we get from our patients, whether the physicians get the questions, our nurses get the questions, our staff gets the questions, things that come up that are almost agnostic and universal to a lot of the patients that we see. And I wanted to keep it more of in a question format where people that have attended the Zoom can type in the chat, can ask us questions that are maybe not specific to them or their disease, but more broad, maybe something that they didn't have the opportunity to ask of their radiation oncology team when they first met. Maybe they're looking for, as another opinion on a specific topic. So happy to give my opinion and share some subject matter expertise. I have no disclosures other than I'm a radiation oncologist and I love what I do and think it's pretty cool. So I'm going to try to tackle these 15 questions today, each of them with a slide. These are the common questions I get, my team gets, and in surveying a lot of my staff that we kind of hear over and over from our patients. And I won't bore you with reading all of them right now, but we'll walk you through them one at a time. As a disclaimer, your own radiation oncology team's instructions take priority because recommendations can vary by the patient, the treatment site, the dose, the technique, and what's being offered to you. So take my recommendations with a grain of salt, but at the same time, there's some universality and commonality with what I'm about to say. So the first question, obviously a lot of people ask, well, what is radiation therapy? Radiation therapy uses high energy radiation to damage cancer cells' DNA, stopping cells from dividing or causing them to die. It's usually a local treatment as compared to chemotherapy. The dose is aimed at a specific tumor or at an area at risk, while the plan limits dose to nearby normal tissues. Radiation therapy can be used to cure cancer or sometimes just reduce the chance of a recurrence, shrink an actual tumor as you see it, or relieve symptoms such as pain or bleeding when cancer unfortunately sometimes travels to the bone or to another organ that could cause bleeding. So radiation is both used to cure but also palliate symptoms from a tumor. And sometimes that's done in conjunction with our colleagues in medical oncology who are giving medicine and other chemotherapies. Takeaway point, radiation is a highly targeted cancer treatment. It's not exactly the same as diagnostic x-rays or what they put you through at the TSA line at the airport, but both use some form of radiation turned up to a degree and aimed with a different purpose. How is radiation therapy delivered? I often get asked, well, how is this going to go? How am I going to be positioned? Is anyone actually in the room with me? Dr. Richter, are you in the room with me? Well, for external beam radiation, you lay on a treatment table, sometimes called the treatment couch, while a linear accelerator, which is the device that delivers the radiation, moves around you from different angles. The radiation itself are really invisible beams that come in from planned different angles to really conform and sculpt the treatment. The radiation therapist positions you carefully, then steps into a shielded area or even outside the room into a control area while the beam is on, so that staff isn't getting exposed to treatment, and so the radiation itself and the machine can move without issue. You are technically never unattended. Every room that we have, every machine that we have, there are cameras. There are microphones. We see you, we hear you, we can react to what you're doing. There's even, in a lot of cases, surface guidance and monitoring to make sure that you still stay in the exact position that you're in, that we want you in for treatment. And we actually do scans every day to make sure that you're lined up before we actually turn the treatment on. The staff is constantly watching you and seeing you, and the beam can be stopped at any time. The treatment can be paused at any time. If you're uncomfortable, if you're out of position, if you have a question or an itch. Obviously, we ask that patients hold still, but patients, commonly need to know, of course, at any one moment, the treatment can be interrupted and paused, and we can always pick it up. You're not alone in the treatment room, but while the beam's on, your therapists are watching you, communicating with you the entire time. As your physician, I'm not in the room with you, and we have licensed therapists that are actually the ones delivering the treatment. I get this one a lot. Am I radioactive? Am I a harm to anyone? Am I emitting radiation? And then with that, can I be intimate during radiation? After external beam radiation, you yourself are not radioactive. You're not giving off radiation. You're not going to get stopped by Border Patrol going over to Mexico or something like that. It's safe to be around family, children, pregnant people. While the treatment's being delivered, radiation is working on the intended area, and it continues to do so at the cellular level, but it's not actually in you, living in you, where you're actually giving it off to anyone. So it is safe to be around everybody. There are forms of radiation, brachytherapy, where we implant radiation, or systemic radiopharmaceutical therapy, where we're actually giving intravenous radiation through more of a liquid format, where temporary precautions, transient precautions, can be required. And for those cases, we give people specific instructions, specific cards, and a real protocol as to how to avoid contact. But the majority of patients, most of you probably listening in, it's usually external beam radiation. As far as intimacy is concerned, again, from a proximity contact perspective, no issue with external beam treatment. But for patients that are undergoing any pelvic radiation therapy, whether for a gynecologic cancer, genitourinary cancer, or what have you, there obviously can be changes to the area with soreness, dryness, bleeding, or even sexual dysfunction. Pregnancy for patients that are actually the ones getting the treatment needs to be avoided. We do not want to expose a developing fetus or even a possible in utero patient with radiation therapy. Kids are exquisitely sensitive to radiation, and we do not want to jeopardize anything with a pregnancy. So not being pregnant during radiation is paramount. If you are of childbearing age, we often get pregnancy tests before starting this process. We advise on contraception during radiation in the case that you want to have a family or develop a family. And it's very important that you ask your team about your fertility and contraception before treatment starts. And don't be offended if your radiation team asks you to do a pregnancy test before we start this whole thing. We just want to make sure we're minimizing any risks. And again, just to hit that home, there are some internal radiations, brachytherapy or systemic treatment, where we give radiation more intravenously or through a vessel, where distance, hygiene, and sexual contact precautions are a bit different. But for the majority of patients, you are not radioactive, not going to fly around like Iron Man or glow in the dark. You're just getting treated when you're here, and you're not getting radiation when you go home. What can I expect as far as side effects? As I tell my patients, there's no free lunch. Anyone who tells you that radiation is 100% effective without any side effects probably isn't being completely truthful. But the reality is most side effects are limited, they're transient, they're manageable, but it's important that we know about them. Side effects really come from what part of the body is being treated, the amount of treatment it's receiving, the schedule of its treatment, and whether other therapies like chemotherapy are being delivered with it at the same time. Most common side effects, no matter what we're treating, are usually fatigue, changes to the skin where the radiation may be coming in from at a different angle, site-specific side effects if you're talking about the GI tract, if the abdomen or the bowels getting treated nearby, nausea, diarrhea, and other GI symptoms can happen. If you're being treated to the head and neck area, you can have changes to your ability to swallow, dryness in the mouth, and so on and so forth. If you're getting treated to the brain or the head, there can be some hair loss. You can have some swelling, things like this. Side effects often build throughout the treatment and can actually peak near the end or even after the treatment's complete. So radiation is cumulative. I often give sort of a stepwise analogy where, the first treatment, you might not feel much anything in the first few weeks. But by halfway or towards the end, you may start to sense how the radiation is coming in and what it's affecting. And just like it takes time to build up, it takes time to taper off as well, descending the staircase, if you will. Most symptoms improve after treatment, but of course, there are some late effects of radiation, which depend on what part of the body is being treated and how it's being treated. And those can occur months or even years after treatment. But the majority of symptoms are usually temporary. It's important that you tell your team early about your symptoms so that side effects can be prevented, reduced, or treated. So I get this question a lot. Am I the one actually administering the treatment? Am I seeing you every day? We sort of touched on this a little bit, but I'm not actually the one pushing the button. I'm the one in charge of prescribing it, overseeing the treatment, but licensed radiation therapists operate the treatment machine daily. They're who you will come to know as you're getting your treatment. They know your plan intimately. They know your positioning issues or asks to try to get you into the right comfortable position. Medical physicists who work in the background and dosimetrists are the ones that help us calculate, verify, and quality check that the plan that we're trying to deliver and the equipment we're using to deliver it are functioning properly. But I do not see you every single day of your treatment unless you want to come and say hi and say what's up. Most of the time, I am seeing my patients, and most radiation oncologists are seeing their patients once every fifth treatment. So about once a week, as part of the radiation process, as part of billing, as part of accreditation. We have to see our patients once every fifth treatment. We can see you more frequently than that, but we have what's called a weekly on-treatment visit. So as part of your radiation schedule, you will get a visit with the physician, usually just after one of your treatments for about 10, 15 minutes. And that's really a catch-up time. What side effects are you experiencing? How are things going? Do any adjustments need to be made? So that's built in. That's not an appointment that you have to schedule separately. Radiation's team-based care. While the doctor is overseeing the course, we work with a whole team of professionals and licensed professionals who are involved in creating a sophisticated plan and then ensuring that that plan is accurately and safely delivered every day. So no, I am not the one to push the button. Can I receive radiation therapy more than once? I get that a lot. I heard I can never get radiation again, or it's a one and done. The reality is, yes, you can receive radiation more than once. Obviously, if it's to a different part of the body or a different cancer somewhere else, that's easy. There's likely no treatment overlap with your prior therapy. But in selected cases, when there is an area of previous treatment overlap, technically, this can be re-irradiated and irradiated again. We're even involved in a clinical trial right now specifically looking at breast re-irradiation. Re-irradiation depends on the dose that was previously received, the time interval in which that new area or the new issue has developed. So the longer the period of time, potentially the more favorable. If there was any or real significant overlap with the new target, its nearby organs, what the goal is of the new treatment, and what techniques are we using to deliver that retreatment. Obviously, this is a very case-by-case specific recommendation as far as re-irradiation, and it's very important that we have your prior treatment records. We know what was given before, and we know exactly what we're intending to give now to really be able to synthesize and analyze whether it's safe to deliver retreatment. It may or may not be recommended for every single patient, but these days we're getting better about it in terms of our sophisticated planning and our comfortability with re-irradiation treatment. So are all radiation facilities and machines the same? I live out in Coral Springs, or, I'm just going to go to, Ohio for the summer. Maybe I'll just get my radiation at the local shop there. No, centers can differ not only in their technology, imaging, and treatment techniques, but the staff, their experience, how they review the treatment, how they discuss your case and review the treatment amongst their peers can differ between facilities. I happen to think we do a particularly good job here. Different machines can often achieve the same clinical goals, but the actual technique and the machinery can actually give you a better plan when it's carefully selected, when it's carefully considered. Accreditation programs, ASTRO, APEX, ACR, these other external bodies that come and look at radiation facilities and cancer programs. They assess safety, quality, personnel, equipment, and it's good to be at facilities that are constantly going through the processes of accreditation because they're keeping up with the times, they're making sure things are safe and quality approved, and we're certainly one of those facilities. Questions that one might ask of a facility if they're trying to go outside of Lynn is the physician in charge of my treatment board certified? Are the facilities accredited? Is my plan peer reviewed? Is it being checked by maybe subject matter experts apart from just my doctor? And I'm happy to say at Lynn, we do all of this. It really is important that the right plan, the experienced team, robust quality assurance, and appropriate technology actually matter more than when a machine was installed, how new is it, or what's the name of the machine. I mean, it's really about what does one do with that machine? Is it being serviced properly? Is my plan being peer reviewed properly? And this is what I think differentiates and sets certain radiation facilities apart from one another. At Lynn, I think at the Lynn Cancer Institute, I think we're pretty locked and loaded when it comes to technology. We have a very busy, profitable department, but we also have a very philanthropic community that's bestowed upon us some state-of-the-art and I would say world-class technology between photon, proton, brachytherapy, and even MR-guided radiation therapy. We really have everything under the sun. So for our patients, in terms of our facility, there really isn't anything we don't have at this point. And we're toe-to-toe and on par with virtually any major academic cancer center out there. So you don't really have to venture very far from your own backyard to be able to get the best care. What's nice about having all the technology is we can really personalize your treatment plan. We can really figure out and even create more than one plan to understand which machine, which technology would be best for your particular cancer. They can all probably do the trick at treating the tumor, but which one's going to give us the least amount of side effects? And I think that is a very individualized, personal, patient by patient decision. And I'm happy to have all of these toys in our department. Do I need to do anything to prep before my treatment? Preparation's key for radiation therapy delivery. Yes. It's treatment site specific, and it's very important that you follow the instructions from your own radiation team exactly how they want you. There may be things that your friend or your aunt did or didn't have to do because obviously their anatomy is different, their case may be different. So it's important you take instruction from the cancer team. Before treatment, most patients have what's called a simulation or a planning scan. You might be receiving a custom mask. You might have a special mold made for you. And it's important that that positioning for treatment at the simulation matches exactly how you're going to be every day. So make sure you tell your team, you know, my arm hurts, or you know what, I feel fine, I have no pain, I feel comfortable in this position, or you know what, doc, I'm laying down too much on my back, I'm short of breath. It's better that we get it right up front at the time of simulation than trying to make adjustments once a treatment plan is ready to go to deliver. Pelvic radiation therapy treatments may require certain preparation based on your bladder, on how much you've eaten that day. We might ask certain patients to fast so that the stomach or the bowel doesn't now infiltrate or start to interfere with where the radiation's going. Same thing, let's say in the case of prostate cancer, we want to minimize the exposure to normal organs. We want to minimize the radiation exposure to those areas. And so having certain healthy organs in the correct position is almost as important as having the cancer in our crosshairs. Wearing comfortable clothing for ease of changing and coming in and getting in and out of the department is important. It's very important that the patient, you know, have some ownership and also let us know, right? Any concerns about pregnancy, if they have any implanted devices like pacemakers or defibrillators, if they've had prior radiation, what medicines are they taking? Did they try anything new recently? Are they doing homeopathic things? I mean, these are things we would want to know up front before we embark on our treatment. So from a preparatory standpoint, that's important. And just take home, consistency matters. We try to get patients on a schedule doing the same thing every day so that the alignment, the anatomy can be spot on, and we can be that much more precise in our treatment delivery and thus reduce side effects and hit our mark. So can I go swimming? Can I be in a pool? Can I get on a boat? Can I jump in the ocean? I get these questions all day, especially in the summer, especially with this past summer. Usual normal activity, including boating, is very reasonable if you feel well, but remember you're outside in the Florida heat. Fatigue, heat exposure, dehydration, the sun, it does require some extra caution. Swimming is acceptable, obviously, if the treatment skin is intact and not irritated. You obviously want to ask your treatment team about that. And I think if you're going to jump into a chlorinated pool or a saltwater pool or a community pool, very important that you just rinse off after, moisturize even if your skin is being exposed to some of that treatment. I would say it's best to avoid swimming if treated skin is open, if it's blistered, if you're having a rash, if something's very irritated, or let's say you're even a case where you're getting radiation post-operatively. I think it makes sense to make sure that what you're swimming in is a relatively clean body of water, but also try to avoid certain bodies of water that may harbor a greater risk of infection. And obviously community pools or hot tubs could do that. Protect your skin from direct sunlight. If you're going to go out to the beach with your family, if you're going to go to the pool, just be smart about it. Sunscreen, SPF shirt, a nice big floppy hat, sit under the umbrella. I wouldn't go baking topless somewhere, but sunscreen and avoiding sun exposure can be best for you, especially as you're going through and right after treatment. Water itself doesn't interfere with radiation, but skin conditions, devices, risks of infection, and sun exposure all really determine what's safe. So just I think moderation is key for something like this. How do we know the treatment's working or not? I get that treatment all the time. I especially get that treatment on an on-treatment visit where patients are meeting with us mid-treatment, where they want to know, well, how's my prostate cancer doing? How's my breast cancer? And radiation effects are not immediate. Sometimes radiation is being delivered as a prophylactic measure. It's trying to treat microscopic disease. So there's really nothing that we're seeing or measuring as far as your cancer is concerned. In the case of prostate cancer, a lot of times we're treating the whole gland of the prostate. And for that, we're really monitoring PSA or biochemical response later on. So cancer cells continue to die for weeks or months after a treatment ends. As we're going through it, there may not be any objective, how is the radiation working on my cancer information to report. We do, during treatment, take daily periodic images, often mainly to verify patients' positions. That's not necessarily to look or measure or calculate how the tumor is doing, but I will say in some disease sites, especially some of the lung cancers I treat, if we treat a big enough cancer to start with, I will see over the course of treatment some shrinkage, and you will see treatment response. You will also be able to monitor, God forbid, in the case where something could be getting bigger before it gets better. Response is usually assessed at the appropriate time using symptoms, physical exam, tumor markers, labs when relevant, and imaging such as CT, MRI, or PET CTs are usually the tools and the evaluation techniques we would use to assess later on how is the cancer responded, what's going on with that patient's labs, these types of things. The timing and type of follow-up is really dependent on the cancer type, what scans are needed to be performed, and certain physicians and certain centers may have a particular schedule they'd like you to follow so that there can be some variability. For many cancers, that meaningful response assessment really happens after treatment, not day by day. So just know that we're watching your tumor. We're really making sure that things are aligned every day to make sure that you're in the right position. But the imaging that's done every day, called image guidance, is really just to make sure that we're hitting the mark. And it's not necessarily a scan to really assess how we're doing, right? The real test is going to be later on in follow-up with some of this other information. So do I need to finish all my treatment? Can I stop early? I get this question a lot, especially for some patients where, let's say, we're treating for pain or for bleeding, or they've seen some cancer regression already, even clinically, and they're wondering, well, do I need to continue it? It's like taking an antibiotic. You get a couple doses in of your Z-Pak and you're like, I feel like $1 million. I don't want to finish the rest of these pills. The prescribed number of treatments and the dose are chosen to maximize cancer control while keeping normal tissue risks acceptable. I would say it's not advisable to stop treatment early on your own. Incomplete courses of radiation deliver less than the intended tumor dose and can potentially jeopardize or reduce the chance of achieving that treatment goal. A lot of the dosing for radiation, the fractionation, the numbers of treatments, the frequency, the dose, that all comes from randomized clinical data from patients that have come before you. The radiation oncology team knows what works. We hope we've selected and personalized a treatment plan that we know is going to be safe and effective for you. So I would say trust your team. Of course, things come up over the course of treatment, transportation issues, hospitalization, other problems, maybe even excess toxicity than was expected. And there may be reasons to adjust a treatment course, whether that's stopping something early, adjusting the dose of the treatment, speeding things up in terms of ease of deliverability, or medications and other supportive cares. These are things that we constantly check in with our patients on that are on treatment visits. Our case management and social work team checks in with patients. But there will be cases, and there are sometimes are cases where physicians may intentionally change or even stop a course of treatment because the clinical circumstance and situation has changed. So I think the more common thing is try to finish your planned course of treatment unless your radiation oncology team recommends to change. And if they are making a change, it's probably for good reason and to your benefit. What if I miss a treatment? What about the holidays? I got family coming in, I slept in, I got a flat tire. I mean, things happen, life happens. I think it's important to call and contact your treatment center as soon as you know you'll miss a session. Oftentimes, we're very willing to make something up at the end of the day or at a different time. We can finagle the schedule a bit to make sure that we minimize missing treatment. I wouldn't assume that that treatment in and of itself can just be skipped entirely. It is true that for some cancers, prolonging the overall treatment time can actually reduce effectiveness of the treatment, especially for things like head and neck cancer, sometimes skin cancer. So it's very important that you speak to your treatment team about it. Radiation departments plan around major holidays. So we may adjust your schedule, add a treatment day on the back end, or use another evidence-based approach to work around some of the holidays. And of course, if you've been with our department or if you've worked with a radiation oncology team, we do try to honor and get patients to be home with family and friends for the holidays. But we don't want to jeopardize your treatment. And oftentimes, if we need to, and we will work through holidays if patients are willing to come in. A single interruption, one mistreatment here or there is not a reason to panic. We can make it up, we can adjust for it, but the key is to let us know how to manage it. And I would say for most patients, we want to from the outset make sure that you're intending to come every day, Monday through Friday, business days to get treated. We're not looking to skip treatments, but of course we can work around your life and your schedule. Try to avoid those unnecessary gaps. So I need to modify my diet during radiation. What about vitamins and supplements? Well, there's no one single radiation diet. Most patients should really aim for adequate calories, proteins, fluids, and stay balanced, right? Unless a certain treatment side effect requires a certain change. A lot of times, because the side effects are site-specific and cancer-specific, right? Where are you getting the radiation to? Also, so does the radiation diet follow where we're treating you and how you should modify what you're doing. For, let's say, head and neck cancer, obviously, if your throat's sore, your esophagus is seeing a lot of radiation, it may not be so easy for you to swallow. We may need to adjust and have you stick to softer foods, bland foods, nothing that's too spicy or acidic, something that's going to go down, like more breakfast foods, right? Eggs, pancakes, stuff like that. If you're getting abdominal or pelvic radiation therapy, you may be more sensitive in terms of what you're eating, in terms of salads or dairy products. So it's very important that you work with our dietitians and nutritionists to come up with a very personalized dietary plan. I wouldn't start high dose vitamins or antioxidants or over-the-counter herbs without discussing these supplements with your radiation oncology team. It's true that some supplements can interact with cancer treatment. Many of our patients aren't just getting radiation. They may also be taking other medications or receiving other chemotherapies or immunotherapies. And for that, we want to make sure that as a team, you're not ingesting something outside of our treatment that could be interfering with the effectiveness of your cancer therapies. Get some questions on sugar. There is no evidence that eating sugar directly causes an existing cancer to grow or that eliminating it entirely makes a cancer shrink. I think moderation is key. I think staying balanced is key. I think when it comes time for vitamins and nutritions, I would say, go with the food first. No one's going to tell you not to drink a glass of orange juice or go grab a smoothie, right? To get your antioxidants, to get your vitamins from a natural, organic way. But I don't think you have to megadose. And to that, there can actually be some interference with how some of these cancer therapies work. I think it's important to talk to both your radiation oncology team and even your oncology team, and get their approval for some of the things that you may be taking in higher doses. I get this one a lot, especially around the holidays, not that it gets particularly cold in Florida. Can I have a glass of wine or cocktail with dinner, right? I'm under radiation. I'm usually a glass of wine a night person, or I'm going out with friends this weekend. I think it's generally best to limit or avoid alcohol during radiation therapy. It can worsen dehydration, certain radiation side effects, again, depending on the geography of what's being treated, such of head and neck cancer, or even some abdominal pelvic radiation therapy plans. So it's very important that you try to avoid alcohol, but if you're going to have something, moderation really is key. If you're a patient receiving breast radiation, prostate radiation, or skin radiation, I don't believe a glass of wine is going to interfere with that actual particular treatment or add excess toxicity. Jokingly, I have Betty White in the corner talking about her particular glass of wine. But it is very important that you ask your radiation oncology team about your individual treatment. It really is, it needs to be personalized. And obviously, I would say try to limit alcohol consumption during your treatment, if only to minimize side effects of the treatment. Other things as far as diet and alcohol, right? Obesity, alcohol, these things over time added up can interfere and potentially are risks for development of cancer. But once you have it, once you're getting treatment, a glass of wine isn't going to upset or derail your radiation therapy treatment plan. I get this question a lot. Am I immunocompromised from the treatment? Again, can I be around other people? Can I get vaccinated? Radiation as a local treatment does not typically suppress the immune system as much as a chemotherapy or a systemic therapy. It can lower some blood counts, especially when large swaths of the body, especially the bones, are being treated. It can lower lymphocytes in particular when large areas are being irradiated, or when more bone marrow is being, when radiation is seeing more bone marrow, and especially when radiation is being combined with chemotherapy. So most non-live vaccines, flu shots, COVID vaccines, things like this, they're generally safe, but I think in case somebody has a side effect from them, I think it's best to try to get through your radiation therapy treatment course before actually getting certain vaccines. Other vaccinations may not be appropriate for patients that are immunocompromised from chemotherapy or immunotherapy potentially, so best to talk about them with your oncology team. I think if you know that radiation's coming months in the future, try to get vaccinated before you start treatment. I think if your treatment course is only a week or 3 weeks, why overwhelm yourself? I think just be prudent, take one thing at a time, and maybe go for that vaccination after radiation's complete and after the side effects of treatment had settled down. We don't want anyone getting sick from a vaccine. We don't want them missing treatment, to my point on the other slide. So sometimes less is more. And with that, I'll just say that radiation needs to be individualized. Always important to follow the specific instructions of the treating radiation oncology team. They may be asking you to do certain things a certain way that are contrary to what I just said for a very specific reason unique to you. And so radiation therapy, the plan, the setup, the delivery, and the treatment is really not a one size fits all. It's really personalized, it's individualized. And the recommendations surrounding it, which we just went over, are also very unique to each patient. And with that, I'll see if there were any questions. I don't think I have the chat up, but I wanted to kind of open it up and see if any of the attendees had any particular questions about anything I said or other questions that they've had or wanted to know about. And thank you for your time and thank you for listening.
Dr. Richter, I actually put a question in and I don't see it coming. Do you see it? I don't see it.
Yeah, I see it. It's under hosts and panelists. Which skin cancers are best treated with radiation therapy? And to answer that question, we do get a lot of referrals for both non-melanoma skin cancers and sometimes even melanoma skin cancer. In the case of radiation being used as a definitive treatment or a treatment in lieu of or by itself for skin cancer, we really focus on the basal cell cancers as well as the squamous cell cancers. For skin cancers like melanoma, Merkel cell carcinoma, and some other rare skin cancers, lymphoma of the skin, or even sarcomas of the skin, a lot of times radiation is used as adjuvant therapy or postoperative therapy in combination with some other modality. So in some cases, radiation does all the heavy lifting by itself for patients with basal cell cancers and skin cancer and squamous cell cancers, particularly in areas of the face or in nooks and crannies where surgery itself might leave a patient more disfigured or with a bigger graft. In cases of some of the rarer, more aggressive cancers, sometimes a combination of surgery followed by some radiation is indicated, and we will see patients for that as well. Radiation for skin cancer can be delivered sometimes in as few as just 2 weeks of treatment. Sometimes we slow it down to be delivered in 5 to 6 weeks of treatment, depending on where on the body it is, how big it is, and what kind of cancer flavor it is. Thank you for the question.
Thank you. Yeah, I think it's interesting that not that many people are aware, I think, that they can have,
Yeah.
that there's
And I
another
think,
option in treating.
yeah, I think if you're seeing, a lot of, I mean, dermatology practices down here like Starbucks in New York City. I mean, there are a ton of dermatology practices. All the patients are being followed. Everybody's got a dermatologist. But I think if, and God forbid, you're diagnosed with a skin cancer, I think it is important to know what all options exist for you, right? What is the menu of potential treatment options? Mohs surgery, generally for basal cell cancer and squamous cell cancer is the standard of care. But we've all encountered patients or have had friends and family where easier said than done, right? Maybe it's on a cosmetically sensitive area, or maybe the patient's had Mohs surgery so many times that they don't really want to be cut again. Skin cancer or radiation for skin cancer is very common. I would say we're pretty expert in that. We see patients, both young and old, and we have excellent outcomes, almost as good as Mohs surgery. So oftentimes it's nice to try that, knowing that surgery could be the ultimate backup option if it didn't work.
Thank you. So anyway, I mean, you answered all the questions, but does anybody else have any questions? If not, our presentations are all recorded. So if you would like to pass this on to someone, one of your patients or family or friends, when Lee sends out the evaluation form, which we really encourage everyone to fill that out and send it back to her, you can also ask her for a copy of this presentation. Generally, it takes a couple of days to be able to provide that, but she would be able to provide it after that. We thank everyone. Thank you, Dr. Richter. We thank everyone who joined us today. And our next Zoom and Connect will be on September 30th. And the topic will be prostate cancer. Know the facts, know your options. And this will be presented by Dr. David Taub, Dr. Agarwal, and Dr. Bacow. So thank you, Dr. Richter. We appreciate all the time and effort and research that you put into this presentation. We know that it's a lot more than an hour out of your day, so we really appreciate that. And thank you to everyone.
Thank you.
Have a good afternoon.